Hello class, my name is Henry Wright and today I'd like to do a little presentation on type 2 diabetes mellitus. The objectives of this presentation will be to define type 2 diabetes, discuss the disease pathology and the body's response to this disorder, to talk about the role of genetics, to discuss the clinical presentation and the physiologic rationale behind the presentation, and finally to go over diagnostic testing. So what is type 2 diabetes? Type 2 diabetes is a metabolic disease characterized by excess glucose accumulation in the bloodstream, resulting primarily from insulin resistance. Type 2 diabetes is the most common form of diabetes. Other types are type 1 diabetes, gestational diabetes, and specific types due to other causes. For example, monogenic diabetes syndromes such as neonatal diabetes and maturity onset diabetes of the young, diseases of the exocrine pancreas such as cystic fibrosis, and drug or chemical-induced diabetes such as with glucocorticoid use in the treatment of HIV/AIDS or after organ transplantation. Let's go into pathology and body's response. As with most physiologic processes, the body likes to maintain homeostasis. In regards to blood glucose levels, the body likes to maintain them between 70 and 110. Alpha and beta cells of the pancreas help maintain glucose levels within this range. In regards to this presentation, we're mostly concerned with the upper half of this graphic. As you can see, as blood glucose levels rise, beta cells secrete insulin, which have a number of effects on the body. These effects lead to glucose concentrations being lowered. So what is insulin? Insulin is a hormone secreted by the pancreas beta cells that stimulates glucose uptake by various insulin-sensitive tissues such as fat, muscle, and liver. This slide is a graphical representation of insulin's effect on the cells. We have free glucose here outside the cell, and then we have the insulin receptors here. In the next photo, we have insulin engaging the receptor, and this starts a cascade of events that ends with glucose being allowed into the cells. Insulin resistance occurs when tissues sensitive to insulin, like liver, muscle, and fat, stop functioning properly in response to insulin. This results in hyperglycemia. As noted in a previous slide, we saw that insulin interacts with receptors on the cell surface to facilitate a cascade of events bringing glucose into the cells. In this picture, we can see by this red X here that something is going wrong, and as insulin interacts with insulin receptors, the cascade of events that tell the glucose transporters to bring glucose into the cell has gone wrong. As insulin resistance increases, the body compensates by releasing more insulin to maintain homeostasis. This can go on for years without any symptoms being present. Eventually, a point is reached where the body cannot produce enough insulin to maintain homeostasis, resulting in hyperglycemia. During this process, we also see progressive beta cell dysfunction, partially due to their extreme sensitivity to high glucose levels. Insulin resistance and progressive beta cell dysfunction with resulting decreased insulin output are the two pathological mechanisms that are the hallmark of type 2 diabetes mellitus. Okay, let's get into the genetics of type 2 diabetes. The genetic component of type 2 diabetes involves inheriting a predisposition to the disease. In a landmark study published in a 2016 issue of Nature, researchers sequenced the exomes of 12,900 people and the complete genomes of 2,600 people, with the participants being split half and half between those with and without type 2 diabetes. Among these individuals, 126 genetic variances were found on one of 4 genes that were significantly associated with an increased risk of type 2 diabetes. The genes identified were associated with insulin resistance and beta cell mass and function. It is important to note that type 2 diabetes involves both genetic and environmental factors. How genetic factors interact with environmental factors such as diet and inactivity to manifest the disease is not yet fully understood and remains the focus of ongoing research. Type 2 diabetes generally presents with nonspecific physical signs such as polyuria, polydipsia, fatigue, pruritus, recurrent infections, visual changes, and symptoms of neuropathy. Polyuria occurs as the kidneys are overloaded by excess glucose in the blood, which is excreted in urine along with large amounts of water. Polydipsia is usually caused by excess glucose in the blood, causing water to be osmotically attracted from the body, leading to intracellular dehydration and hypothalamic thirst stimulation. Fatigue is caused by metabolic changes resulting in poor use of food as energy. Pruritus is caused by fungal infections favored by hyperglycemia and glycosuria. Recurrent infections can be the result of microorganism growth stimulated by hyperglycemia. Patients can present with visual changes such as blurred vision that are caused by water balance fluctuations in the eye due to excess glucose in the blood. Signs of neuropathy are seen as the nerves are especially vulnerable to chronic hyperglycemia, which leads to demyelination, nerve degeneration, and delayed conduction, which manifests as symptoms of neuropathy like paresthesias or weakness. following two slides contain information pulled from the American Diabetes Association Standards of Medical Care in Diabetes, released in 2017. Diabetes can be diagnosed based on the results of the following diagnostic tests: fasting plasma glucose, a 2-hour plasma glucose after a 75-gram oral glucose tolerance test, A1C criteria, or a random plasma glucose in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis. Diagnostic criteria are a fasting plasma glucose greater than or equal to 126, a 2-hour plasma glucose of greater than or equal to 200, an A1C of greater than or equal to 6.5%, or in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose of greater than or equal to 200. Plasma glucose tests measure your blood glucose level at the time the test is taken. Type 2 diabetes is characterized by hyperglycemia, and a plasma glucose test would measure this increase in blood glucose with results in the diagnostic range for the disease. When there is excess glucose in the blood, it binds to blood hemoglobin. The A1C test measures this glycosylated hemoglobin and reflects the average of a person's blood glucose level over the past 3 months. A person with type 2 diabetes would have an A1C level in the diagnostic range for the disease. Thank you for watching this presentation.